Good afternoon, everybody. Welcome to Pulmonary Grand Rounds. It's my pleasure today to introduce our speaker, Dr. Perry Wilson. Dr. Wilson is a graduate of Harvard College, where he majored in biochemistry. He then went on to Columbia College of Physicians and Surgeons, where he graduated in 2006. Got all the awards, Perry. AOA, Gold Humanism, Robert F. Loeb for excellence, but my favorite one is the Charles F. Hamilton Award for Excellence in Pulmonary Medicine. but somehow we lost Perry to nephrology. But he went on to do his internal medicine residency and nephrology fellowships at the University of Pennsylvania. After 2 years on faculty at HUP, he came to Yale in 2014 as an assistant professor. He's held numerous key positions here. He's the director of the kidney work group of the Veterans Aging Cohort Study, board of directors at Gaylord Specialty Healthcare, deputy director of the Human Genetics and Clinical Research Core, the course director of interpretation of the medical literature on the Yale Coursera. He's been the director of the Applied Translational Research Program and the director of the Clinical and Translational Research Accelerator. Perry has numerous grants. He's had many national and international speaking engagements. His area of scholarship is in interventional data science, particularly machine learning, clinical decision support, and best practice alerts. Last I looked, he has over 160 publications in PubMed in such distinguished journals as BMJ, Nature Communications, Nature Biotechnology, JCI, American Journal of Kidney Disease, JACC, and JAMA, just to name a few. This is a very exciting talk today. I think it points our way to the future of artificial intelligence and how it's going to help us do our jobs better. The title of Perry's talk is Interventional Data Science, Making the Machines Work for Us. Perry, welcome to the podium and thank you for joining us.
Thanks, everybody. Thanks, Mark. And thanks, Debbie, for setting this all up. It's great to be in the Ficken Amphitheater again. It's always exciting. Feels very old school to be standing at the bottom of something and have everyone look down on you. I feel like we should wheel in a gurney and do a dissection, but instead, we'll do this. Today I'm going to answer the question, what would you say you do here? And usually I tell people we do interventional data science, which is applying the tools of data science, like real-time analytics and machine learning, to target interventions to patients at the point of care. So we take the interventional seriously. We think that these new tools in digital health and data science should be used to improve the care of patients and ideally to improve their outcomes. And anything sort of short of that is incomplete evaluation of a new technology. So I'm going to talk about 4 studies today that are loosely related, like a few X-Files episodes where they do stand alone, but I think there's a current running through of something darker and deeper underneath. These are all electronic health record-based studies. That's where our lab really got our start, is in pulling data from electronic health record and the techniques involved with cleaning it and stuff, and using it for research purposes. And I'm going to share with you some of the challenges that these studies have, the things that don't appear in the papers, because I'm hoping that this will spark some interest in either collaboration directly with us or people just trying this stuff on their own. And I don't want anyone to make the same mistakes that we did. So I'm going to start with our probably simplest and maybe most prototypical clinical study that demonstrates the use of real-time analytics and how efficient that can be in terms of clinical research. And this is an evaluation of a very common sense intervention. So I am a nephrologist, but I still love pulmonology. And AKI is a major problem for us in the hospital. About 15 to 20% of people in the hospital will develop AKI. About 50% of people in your ICU develop AKI during their hospital stay. And if you're a patient at one of our hospitals and you develop AKI, and the definition is there in that blue box, so a very mild increase in creatinine, your inpatient mortality is about 10%. Whereas the baseline inpatient mortality at Yale New Haven Hospital for individuals who have 2 creatinines, in other words, people who you could detect AKI is 1.5%. So associated with significantly bad outcomes. And there's some observational data that suggested that getting people like me involved early in the care might improve outcomes, although it was never terribly rigorously evaluated. But there's a problem. AKI is asymptomatic broadly. The patients don't particularly complain about it. And we had data, again, from the electronic health record suggesting that providers don't recognize AKI, with documentation rates of acute kidney injury hovering around 30% among people with AKI in our hospitals. Now, you are no doubt thinking that you've probably recognized AKI before, but not necessarily documented it. And nevertheless, it is in your head and you're thinking about it. So we look at other sort of markers. And this was a study we did with colleagues at the University of Chicago to look at the rate of best practice completion for individuals with acute kidney injury. So there are guideline-directed best practices for AKI. There are no universal treatments for AKI, but there are best practices. And that includes things like getting a urinalysis within 24 hours of acute kidney injury, continuing to monitor creatinine, following urine outputs, and avoidance of nephrotoxins, which is why those helpful renal consult notes always say, avoid those nephrotoxins. And so we looked at individuals across our hospitals, again, Chicago and here, that had severe AKI, a doubling of creatinine. And we found that these best practice measures, even in the severe AKI group, were pretty inconsistently performed. Perhaps most concerningly, we looked at people who were receiving medications, for example, NSAIDs, that you should probably discontinue when your patient develops AKI. And we asked a simple question. We said, among the people who were receiving an NSAID when the creatinine bumped, how many of them got at least one more dose of NSAID within the 24 hours after the creatinine bump? So just, that the drug wasn't stopped and they got at least one dose into them. And the answer was more than 50%. You can see the numbers for ACE inhibitor here, although I think there's a better argument to continue ACE inhibitors than there is to continue NSAIDs in this population. So we established some observational data first to suggest that AKI is bad, AKI is under-recognized, and we have a common sense solution to this, which would be, well, let's just tell providers that their patient has AKI. Our theory being that AKI is a little bit weird of a diagnosis. It's the only one I can think of that is based on the change in a lab value instead of an actual lab value. So we diagnose hypertension by an absolute number on systolic and diastolic, but AKI requires doing a little bit of math, right? The change in creatinine over time, and that might be something that in a busy hospital day providers aren't doing. So should we do alerts to tell providers that their patient has AKI? And we designed this as a randomized trial, and a very simple, pragmatic randomized trial. We created a sniffer that lives in the electronic health record. It's still there today, watching all the patients for various studies that we're doing. It automatically determines when people have AKI at the very moment the lab reports that creatinine value. And then for this trial, it would randomize at the patient level to either inform their providers or not usual care. Now, when we proposed this trial, some people asked questions about the ethics of this. Can we know that a patient has a clinical problem and not tell the provider? Is it ethical to do that? To sort of stand back like, Star Trek Prime Directive style and let the natives, see what happens. And if you are concerned about that, then keep it in mind as you see the results. So our original alert looks something like this. Some of you, if you were here years ago, might remember this. It gave a bit of information about the creatinine levels in the patient, and some language that this patient was in a clinical trial, as well as access to an order set and to add AKI to the problem list. But one thing I want you to know, and something that certainly we've learned both locally but also internationally, is that this is a purely informational form of clinical decision support. We're just telling you, hey, your patient has AKI. We're not giving you very specific recommendations. And as we move on, I'll try to argue that it's those recommendations that make all the difference. In any case, this was a trial of 6,000 patients across 6 hospitals in the Yale system, or 5 if you count St. Raphael's and Yale New Haven as the same hospital, about 3,000 in each group. And they were followed for the clinical outcome of progression of AKI, dialysis, or death within 14 days of randomization or discharge. And because of that, we have no loss to follow-up. But before I show you the results, I promised I would tell you a little bit how the sausage is made. So if you're thinking about doing these kind of studies, I'll warn you that the price of real-time research is eternal vigilance. So these patients are getting enrolled in real time. It's all happening within the electronic health record. They're getting randomized without even any, approval from a principal investigator or anything like that. And so we're constantly following metrics, typically on a weekly basis, pulling data from the EHR to make sure everything's working properly, because the EHR is not really designed to do this. We're hacking our way into it. So this is an example of one of the graphs that we looked at on a weekly basis. This looked at the median number of alerts per patient across the 6 hospitals. So what we were looking for was big spikes, which would suggest that patients are alerting too much, that something broke and the alerts are firing perhaps not on patients who have AKI, and big dips like you might see around week 59, where all of a sudden everything goes to 0. And in fact, that was an epic upgrade that happened to break the alerting system. We were able to get it back up and running within a week or so. But if we hadn't been monitoring that, I'm pretty sure no one would have told us about it. We follow a lot of metrics in these types of pragmatic studies, the number of patients randomized, of course, but also the number of providers exposed, the alerts per patient, the alerts per provider, the alerts per location. We have a second AKI sniffer that works on a different data source to validate the real-time one that's going on. And I'll give you just an example of, again, another example of why following this data in real time is so critical as these trials are going on. So one of the things we calculated on a weekly basis was a variable we called lag. So when the lab results, the creatinine that defines AKI, so that the creatinine goes up, we identify that patient. They are not randomized in this trial until someone opens the chart, because that's the earliest time that an alert could be shown. You can't show an alert to someone when their chart's not open. And so randomization occurs with some delta between whenever the lab results the value that defines AKI and whenever the next person opens the chart is. And that delta we monitored, and it was about 30 to 40 minutes, because people open charts all the time. Not a very interesting variable, more or less a nuisance. But on this day, you can see a negative lag, which suggested that the patients were getting randomized before they developed AKI, which, we're not getting deep into AI right now. So this isn't Skynet figuring out how to predict AKI on its own. We didn't invent artificial general intelligence yet. No, the clue is that this all happened on the same day. And that was a hint enough to suggest to me that I needed to email Julie down in the clinical chemistry lab and say, hey, did you do something with creatinine on this day? And she said, oh yeah, we had some corrections made that day for creatinine. The reagent volume was incorrect, but all patients that were affected were repeated and corrected, and corrective action has been taken. It won't happen again. Fine. Lab errors happen. So a bunch of creatinines had been measured slightly higher than they really were. And because of that, and because AKI is defined by changing creatinine, you had a bunch of people who were defined as having AKI who didn't actually have AKI. The alert has no idea, the algorithm has no idea that a lab error can occur. Or certainly, even with outlier detection, yeah, it might have thrown out if the creatinine was 20 all of a sudden, but minor errors in creatinine, it's not going to pick up on. And this is just a reminder that when you build these things, you often test them on retrospective data to see if it works. But your retrospective data is much cleaner than prospective data, because things like this have already been fixed. When the lab fixes, this often surprises people, when the lab fixes a value, it doesn't retain the old value. That gets overwritten, it's gone. So when you pull that data later on, you just see the updated and fixed value. So even before you do your data cleaning steps on retrospective data, the data is already cleaner than what you'll get prospectively. And there's no way to know how it's going to work until you actually try it. Which is why we do a lot of silent testing of these alerts. We let them run, but don't show them to anyone to make sure that they're working as expected. All right, some results. Our composite primary outcome was a composite progression of acute kidney injury, dialysis, or death. And I'm showing this stratified by our teaching versus our non-teaching hospitals where we conducted this. This was a pre-specified subgroup analysis because we hypothesized that alerts would work better in the non-teaching hospitals, with the theory being that at a place like York Street, you've got a whole team of people that are seeing this patient. You know, you've got residents and interns and attendings, and someone's going to know that the patient has AKI. But in a non-teaching hospital, you have fewer eyes on the patient, and maybe alerts are more beneficial. But of course, we didn't see that. As you can see here, the composite outcome rates were actually higher in the alert group than the non-alert group in those non-teaching hospitals. And if you like Kaplan-Meier curves, that's hospital 5 and 6 here. These are obviously smaller hospitals. This is a subgroup analysis. This could be a false positive, but when it comes to harm, we feel like we're more obligated to explain this than if this were a benefit and we could say, this is alpha error. Oh, sure. You want me to do it?
Excuse me.
Oh, okay. Good. Okay. So I'm going to disappoint you a little bit. What was going on here? My first thought, probably your first. I'm curious. What's your first thought? Why would AKI alerts hurt people? Pulmonologists, I feel like, would think the same thing that I do. Why would alerts for AKI lead to harm potentially? Yeah. What do you think that, I'm just curious, what do you think the thing, I think you guys might think the same thing that I did when I first saw this. Yeah, that's what I thought. I thought it was IV fluids. You know, this patient is AKI, let's give him some fluid, but we know that, you know, fluids can be bad. So we did a formal mediation analysis, which is a statistical process to measure the amount of an effect that is, you know, that flows through a particular intervention. And as you can see from the markers of fluid overload that I have here, we looked at every possible way to get at fluid overload, whether it was bolus administration or just total volume of fluid or even oxygen saturation or something to see if this was the problem. And we didn't find it mediated by any of those things, nor renal consults, if renal consults are fatal for some reason, or the use of diuretics or the avoidance of contrast or something like that. So this is unsatisfying, and I apologize, but I will say that if we had seen just the opposite effect, if in the non-teaching hospitals we saw a benefit of alerts, you probably wouldn't expect me to explain it all through one mechanism, right? I would say, oh, I don't know why they fared better, but you know, everyone was paying more attention. You know, a lot of different things happened that improved care. And if we would have accepted that explanation, we probably have to accept the opposite explanation, which is that sometimes maybe paying more attention or it's different things for different people that can cause harm. Or it's alpha error in the setting of a subgroup analysis. But I put this in here to remind people that this was a common sense intervention that some people said might not even be ethical to have a control group for, because you know the patient is AKI and therefore you're obligated to tell the providers about it. And this is just an object lesson that if you have not tested that, then you don't know. There could be off-target effects, and interventions like this are interventions just like any other thing. And until you actually do your randomized trial, you don't know what the side effects are. So this is real-time research, efficient, cost-effective, pragmatic. These give actionable information to your health system. You don't see alerts like this anymore because we did this trial and we found that they didn't improve patient outcomes, and that's good because you guys don't like alerts, I'm sure, and we don't like them either. We only want the ones that actually help patients. And the results may surprise you, but that's good. That's why we do science. So after we published that and finished that trial, there was a lot of interest in the UK in AKI alerts. And in fact, the UK National Health Service has mandated AKI alerting across all England hospitals. They can implement it in various different ways. It doesn't have to be a pop-up alert like ours, but regardless, they have to notify the physicians that AKI is present. They take it in some ways more seriously than we do. Hasn't been terribly rigorously evaluated. Our colleague Nick Selby over in London conducted a step-wedged randomized trial where he linked an alert to an AKI bundle, a checklist essentially, that when a patient had AKI, that the provider would have to document that, yes, I did these things, right? I examined the patient's volume status. I reviewed the medication list. The checklist was the same for every patient. It wasn't, you know, it was just a generic AKI checklist. But what he was able to show in this trial was that the use of the alert coupled to the checklist reduced length of stay and increased the diagnosis rate of AKI, or at least the documentation rate of AKI, without having much effect on AKI mortality. We took from that, okay, informational alerts are probably not sufficient. We need to tell providers what to do. And as we were designing these trials, this body of literature was really coming into its own in terms of the clinical decision support literature. And people were showing in multiple different spaces that just nudging a provider and telling them what's going on without giving specific actions often doesn't do very much. So we did our second trial called ALIA-2, targeted just at drugs. So we decided to go very narrow here. In this case, we coupled the AKI alerting infrastructure to a little module that would detect if the patient was receiving one of 3 drug classes that we were interested in. And I'll show you what they are in just a second. And so now the alert said, yes, your patient is AKI, but also they're receiving this medication we don't necessarily like, and perhaps you should click here to discontinue it. These were the 3 classes, and people ask me about this a lot because they're a little ersatz, I suppose. But there is logic here. For one thing, if you wanted to build an alert around the concept of a nephrotoxin, you would be hard pressed to come up with a reliable list of what is a nephrotoxin. Aminoglycosides, sure. Lasix, maybe. ACE inhibitors, contrast, depends. Very difficult to do that. And so we decided, let's take one category of medication that everyone agrees no one should get when they have AKI, NSAIDs. That's easy. No Toradol during AKI. Then we decided, all right, let's use this model because we're going to randomize. Let's use this to detect whether something we're less certain about, in this case, ACE inhibitors, matters in AKI. Should you discontinue ACE inhibitors in AKI? Should you not discontinue ACE inhibitors in AKI? There is some question here. The physiology, just for those of you who love this kind of thing, is that when you're on an ACE inhibitor, you have dilation of the efferent arteriole, which of course decreases hydrostatic pressure at the glomerulus and therefore decreases GFR, which is not what you want to do when a patient has AKI. But by dilating that efferent arteriole, renal blood flow increases. And where does the blood flow after it goes through the efferent arteriole? To the peritubular capillaries. So if you have ATN and tubular damage, there's actually a very good biological reason that you might want to keep someone on an ACE inhibitor. So we said, let's use this trial as an opportunity to test whether we should keep people on ACE inhibitors or not by nudging providers to potentially stop them in a randomized fashion. And then there's PPIs. PPIs is sort of a special interest of some of our lab members. We have some decent biomarker data to suggest that subclinical acute interstitial nephritis is quite a bit more common than people tend to think. The cases of AIN that rise to the level of a kidney biopsy are just the most severe tip of the iceberg. And obviously a lot of people are receiving PPIs in the hospital. We thought, let's do a kind of experiment here to see if this contributes to overall AKI burden. Again, another highly pragmatic randomized trial. In this case, we randomized 5,000 people. We did not randomize any patients at the 2 non-teaching hospitals from ALIA-1 after consulting with the IRB because of the concern of that harm signal that was there. Sorry, so inclusion-exclusion criteria are here. Pretty much any AKI patient was fine, provided they didn't already have end-stage renal disease or transplant or already on dialysis or hospice. And our primary outcomes were the same, a composite of AKI progression, dialysis, or death. But we added a process outcome. How often would providers discontinue the medication we wanted them to discontinue? And we had some safety outcomes because here we were telling a specific thing, like maybe you should stop the NSAID, and we had to worry, if we encourage people to stop NSAIDs, are they going to add opioids or something else to control pain, which might be a negative off-target effect? These are very typical AKI patients in our hospital system with median age 70, 50% female, 20% Black. A fair burden of CHF and diabetes won't surprise you, and modified SOFA scores. We did enroll in the ICU, but broadly speaking, most of these patients develop their AKI on the floor unless they were admitted to the ICU directly. This is how those medications of interest break down. So 65% of people in this cohort were receiving a PPI, but there's obviously overlap. And there were even patients who were receiving all 3 of our medications of interest. So when we look at the process outcomes, we're looking at the rate of discontinuation within 24 hours. So this is giving providers a relatively short time window to actually achieve that, which is potentially why we see not quite as much separation, but it certainly is statistically significant. So overall, the process outcome, we saw about a 10% relative increase in discontinuation rates. And across PPIs, a 26% relative increase. It's not surprising that the discontinuation rate for NSAIDs was highest because people are aware that they should discontinue NSAIDs, and the overall discontinuation rate was lowest for PPIs because probably very few people except me and the other people in my lab even think about discontinuing PPIs in the face of patients with acute kidney injury. The clinical outcome overall, you can see here. So fortunately, we did see better outcomes, so lower rate of dialysis, death, and progression of AKI in the alert group, although it doesn't achieve statistical significance. We obviously had pre-specified 3 important subgroups, which were patients receiving one of our 3 medications of interest, and there we actually saw better outcomes in the group receiving proton pump inhibitors. So an interesting finding there that we are exploring further in some additional studies. In terms of subgroup analyses, I don't see too much interesting here except this one little finding, which I'm highlighting because it's come up 3 times now in 3 separate studies of AKI alerts of ours, which is that people with lower baseline creatinine seem to do better with alerts. This rings a little true to me. You have a little old lady with a baseline creatinine of 0.4 and it goes to 0.9. That's pretty severe AKI. You know, that's more than a halving of kidney function. But 0.9 doesn't. No one gets nervous about 0.9 when they see that number. It doesn't turn red on Epic. And so I don't want to overinterpret subgroup analyses, but I will say that we've seen this before, and this population of people with kind of low baseline creatinine is an interesting target for the future. In terms of those safety outcomes, we were glad to report no real differences. Pain scores were pretty high in the NSAID group, as to be expected, but they stayed high and similar between alert and usual care. There were lots of opioids being used, but no difference between the alert and usual care group. Similarly, in the ACE inhibitor group, we didn't see spikes in blood pressure or the need for mechanical ventilation on the basis of pulmonary edema. And in the PPI subgroup, we didn't see any evidence of acute GI bleeding, which was the main concern we had there. So is this real? You know, why might alerts benefit those people on PPI? Well, the relative effect of alerts on discontinuation was highest in the PPI group. So to the extent that medications matter, we had the greatest opportunity to prove that in the PPI group. As I said, we thought that PPI might be an under-recognized contributor to AKI in hospitalized patients. This seems to support that. It's a subgroup analysis. Alpha error could just be random. You know, you get unlucky with your trial that shows your alerts cause harm, and you get lucky in your trial that shows that PPIs, that they're beneficial in PPIs. And of course, there's the possibility that PPIs, it's not the PPI, it's that PPI users have a unique phenotype. And they certainly do. This is looking now based on people who were in the trial that were on PPIs, 3,300 people versus the 1,700 people who were not on PPIs, just looking at their baseline characteristics. And you can see PPI users were quite a bit sicker, so 28% of them in the ICU at the time of randomization. They were more likely to be medical. They had a slightly higher creatinine on admission and at randomization and slightly higher SOFA scores. So it's certainly a different group of patients. And we have some interesting artificial intelligence algorithms that can learn the phenotype of patients that seem to benefit from alerts. And the ALIA 3 trial, which uses that algorithm to target alerts potentially just to the people that will actually benefit from them, is running right now, but in silent mode. So you haven't seen it yet, but we are actually getting data just to make sure everything works before it goes live to see if we can target better using a multivariable model. So automated alerts for AKI can increase the rate of cessation of potentially nephrotoxic medications without endangering patients. Limited evidence that these alerts change clinical outcomes, except potentially for people who are receiving PPIs. So stay tuned for a dedicated PPI-oriented trial at some point in the future. Doing all right. Okay. So I wanted to move away from acute kidney injury to show how you can do this in other settings, and had a nice collaboration with some of our colleagues like Nihar Desai and Tariq Ahmad in cardiology to create the PROMPT-HF trial. And this is the pragmatic trial of messaging to providers about the treatment of heart failure. This is a trial of HFrEF patients, so heart failure with reduced ejection fraction. There are about 6 million people in the country that have HFrEF, and unlike AKI, which has no specific treatments, HFrEF has 4 guideline-directed medical therapies, or GDMT. So according to the American Heart Association, every patient with HFrEF who can tolerate them should be on a beta blocker, a mineralocorticoid antagonist, and renin-angiotensin receptor inhibitor, and now an SGLT2 inhibitor. And there is not only individual level data for each of those classes of agents that at least certain drugs in those classes prolong the life of people with HFrEF in randomized controlled trials, but there's even data to suggest that the more you get people on, the longer they live. What we're battling in this study is what we call therapeutic inertia, which is you have a patient. These are outpatients. You're seeing them in clinic. They're clinically stable. There's not a lot of energy to add something new to the regimen unless that is a specific goal. And so we designed PROMPT-HF to try to overcome some therapeutic inertia. And this was one of our more complex clinical decision support systems. You can see the EPIC color scheme here. We don't have much control over that, unfortunately. Don't love it. It is what it is. This is an example. You can see that it pulls in real-time data about the patient to help a provider make a decision. This is a fake patient because the potassium is 16, so can tell that this is most likely not an outpatient from the actual study. And it very clearly highlights the 4 classes of guideline-directed medical therapy. It tells the provider which medications in those classes the patient is already receiving, and more importantly, which ones they're not receiving. And it even pulls in some information that says, oh, hey, you know, maybe the reason this patient isn't receiving an MRA is because they have an allergy intolerance to mineralocorticoid antagonism. So it makes it very clear for the provider that something is missing, and we hope starts to overcome that feeling like the patient's doing fine, I don't need to do anything. This was linked to a smart set, and the smart set is pre-populated, again, by those 4 classes. It will only show the classes of medications that the patient is not on, because we don't want providers to inadvertently double people up on beta blockers or something like that. So in the example patient I showed you, the beta blocker section would not have shown up here. And the drugs listed here are all the ones that are that have an FDA indication for heart failure with reduced ejection fraction. So your favorite beta blocker may not be here, but we didn't want to overwhelm people listing every possible beta blocker, and we figured FDA indication is probably the best proxy for what we should tell people to do. This is an outpatient study. And so we designed this as a cluster randomized trial. And for those of you who think about this stuff a little bit, the reason we did a cluster randomized trial here is because of the issue of contamination. So let's imagine that you did a simple randomization of a trial like this, which means at the patient level, some patients would generate alerts saying, hey, I'm not on an SGLT2 inhibitor, and some patients wouldn't. Well, as a heart failure provider or a primary care provider, which were the groups we targeted for this study, you'd see some patients with HFrEF, and this thing would pop up and tell you what they're not on, and then you'd see some that nothing pops up. And the concern is that you would learn, as that happens, what the 4 pillars of guideline-directed medical therapy are. And you'd also know that we're watching you and paying attention to whether you're prescribing these things. So you might be more likely to prescribe them to your control patients, even without an alert, because now it's just in your workflow that when you see a HFrEF patient, you add the SGLT2 inhibitor. So cluster randomization gets around that to some extent. So we randomize at the level of the provider. So some providers see alerts for every patient that comes to them, and some providers don't see any alerts for any patient that comes to them. It doesn't fully prevent contamination because, of course, people can talk to each other. We're all colleagues here at Yale, and someone might say, oh, hey, I saw that this alert came up. And of course, we consented these providers to be part of the study, so they knew we were up to something in terms of therapy for heart failure. But it's probably better than simple randomization. We recruited 1,300 individuals into the study within about 6 months. So just an example of how efficient this type of research can be, where you're building things right into the electronic health record that can get delivered at the point of care. And when you look at our baseline characteristics for this study, you can see what looks like a very standard HFrEF population, actually nationwide. And it's really interesting. The New Haven catchment area has almost the exact same demographics as the United States as a whole, which you can put in your grants if you're doing studies around here. We are like exactly as diverse as the rest of the country on average. So anyway, 30% female, 17% Black, with an LVEF average of 30% because these patients have HFrEF. And I do want to highlight that our cardiologists do a great job at baseline. They've got 85% of these people on beta blockers, 70% on ACE/ARB. Mineralocorticoid antagonist at 30% is like double the national average for guideline-directed medical therapy. And then SGLT2 inhibitor use, this trial was done a few years ago. So nowadays you'd say, oh, that's not that great. But actually, when this trial was being done, those rates of SGLT2 inhibitor were also higher than the national average. So we have very good heart failure doctors and primary care doctors here, which would make it harder for alerts to be successful. But nevertheless, our primary outcome was an increase in the number of pillars of the 4 pillars of GDMT within 30 days of randomization. And we saw a significant increase to 25.7% in the alert group compared to 18.8% in the control group. This actually persists. I'm not showing you the data, but this persists at 6 months and a year. Even after we stopped, we fully recruited the trial and stopped alerting. We followed the patients, and the alert group still has higher levels of guideline-directed medical therapy. So there is some longevity to these things. You know, once you get someone on a medication, they do tend to stay on the medication, barring a hospitalization or a complication. And these alerts have actually just been turned back on for certain providers in the outpatient world because of this, because we were able to demonstrate pretty rigorously that they're effective. There's a lot of interest in this around the country when it was presented, and we are now the data coordinating center for the PROMPT-HF Consortium, which is 5 hospitals, 6 including Yale, that are all implementing this, and will share data centrally and be able to look at more important clinical outcomes like hospitalization and death, which is, of course, high interest. So some lessons here: cluster randomization can address the issues of contamination in clinical decision support trials. Definitely think about that if you're thinking of doing studies like this. It's quite hard in the hospital, though, because our teams move around so much and you have people shifting in and out. It's very hard to define clusters in the hospital. But simple prompts, presented clearly, can meaningfully increase the use of GDMT in heart failure. But if we're going to establish clinical benefit, we need larger studies, longer follow-up, and we're working on that. The last thing I wanted to discuss with you all, in order to leave some time for questions, is ties into the issue of prediction of outcomes and how we handle some of these new AI models. And there's a problem with prediction in medicine, and I call this the Cassandra problem. So this is a painting of Cassandra, priestess of Troy. Cassandra was the daughter of King Priam and the brother of Paris. And she was very beautiful. Because she was so beautiful, Apollo gave her the gift of prophecy. So she would see the future with perfect clarity, but she then spurned his advances and he was very upset. And so he cursed her that no one would believe her predictions. So Cassandra has the perfect prognostic ability, but no one listens to her. And in the Aeneid, it's said that she goes to her brother Paris before he goes off to Sparta to abduct Helen. And she says, no, don't abduct Helen, because if you do, the Greeks are going to come and they're going to destroy Troy and we're all going to die. And, Paris didn't listen to her and he goes and takes Helen of Troy, and that sparks the Trojan War. The problem here is that when we think about AI in medicine, there's this prediction level arms race that's been happening where, every new paper in whatever the domain is, okay, well, we have a larger model, we trained it on more variables, and our prognostic accuracy, our predictive accuracy has gone up by 0.01 compared to the best prior, and then the next paper comes out and they improve on it still. We have a new algorithm, we have a new data source, and so on and so forth. The reason I bring up Cassandra is that even if you're perfect at predicting something, that's not the end. You actually have to show that the ability to predict something can meaningfully change outcomes. So how did we start to explore that? We, again, with our cardiology colleagues, designed a study called REVEAL-HF. And the idea here was that patients hospitalized with acute heart failure exacerbation are quite sick. And there are guidelines from the AHA, as well as some international societies, that say that risk stratification should occur on admission to the hospital to help guide clinical decision-making. And everyone pats themselves on the back and says, yes, let us risk stratify. This is good. Everyone shall be risk stratified. But no one was exactly sure what they meant by that. There are a lot of different clinical criteria score for heart failure in terms of how risky it is. So we built a model predicting one-year mortality. We did this using Yale data, so it's an in-house model. We took, I think, 15,000 or so heart failure admissions from the past, and we looked at a variety of clinical parameters, and we made a model that predicts the possibility that this patient will die within 1 year. And then to prospectively evaluate this model, we built it into the electronic health record, and it looks at about 20 variables in the electronic health record, some labs, some vital signs, some demographics, and so on. It calculates the risk of one-year mortality, and then it shows an alert like this. There's some interesting features to this alert, which I like and we're reusing in some other studies. Number one, the alert level sets for you. So if I told you that your patient had a 34.1% risk of one-year mortality, you might think that's extraordinarily high because it sounds terrible. But actually for a heart failure patient admitted with acute heart failure exacerbation at Yale New Haven Hospital, it's not that high. It's on the higher side, but it's not that high. In fact, the average patient at our hospital admitted with acute heart failure exacerbation has a 15 to 30% one-year mortality, worse than most metastatic cancer, right? This is a very bad disease. So we have a graphical display to key you into what this number means, which I think is quite important. We also added these fun buttons, allowing providers to feed back to us whether they think we're right or not, right? Because providers see things that the machine doesn't, like what the patient looks like and what they sound like, and they get a lot more information. We're curious if they could modify the predicted risk in a meaningful way. This alert was done as a randomized trial. So half the patients with acute heart failure exacerbation would generate alerts like this for their providers and half would not. Looking at baseline, this is an inpatient population, all comers with heart failure exacerbation, so not just HFrEF. So in that case, you end up having about a more even split between men and women, 50-50, 20% Black, LVEF, median 55%, and about 30% of people met HFrEF criteria. The BNPs are obviously fairly high, and about 20% of them were in one of our ICUs. Now, the models were okay. These are AUCs of 0.74, which is good, but not great, certainly not Cassandra levels of prediction. But what you can see is that the AUCs were fairly consistent between when we derived the model using retrospective data and when we did the trial itself. But what was not the same was the calibration. So on the left, you can see this is a calibration curve. For those of you who haven't seen this before, the way this works is that you bin people in a range of predictions, let's say 20 to 30% one-year mortality risk. And you would expect, if you take people that we predict have a 20 to 30% one-year mortality, and you wait a year, that 20 to 30% of them should have died. And so that's that green line, right? That's how well you're calibrated. What you can see is, although the AUC of the model, the discrimination of the model was the same between derivation and validation, the calibration was much worse. And in fact, at every predicted probability of death within a year, the observed probability of death was substantially higher. And the reason this is because there was a pandemic going on. And so that delta that you're seeing here is excess deaths due to COVID. This persists even if we exclude people who had COVID, or at least who we knew had COVID. So this might reflect not just COVID itself killing people, but all the the compromised care that happened during the initial stages of the COVID pandemic, particularly for patients with severe heart failure that are getting hospitalized with heart failure. The lack of ability to get in to see your physician and get your lungs listened to and meds titrated quickly and stuff could have been a serious problem. So there is a lesson here. I think people often check the discrimination of their models over time to make sure that they kind of continue to predict well. But if calibration is important to you, it's much more sensitive to kind of the vicissitudes of changes in your cohort and from changes from one hospital to another. So recalibrating models is probably a good idea. It's hard to do in the context of a clinical trial because obviously you have a protocol, and there may be ways to recalibrate your model during the course of a trial, but it takes a better statistician than me to figure out how to justify all that. So I'm going to show you the observed outcomes here. And I know there's a lot on this slide, but first just look at the trend of these batches of 3 bars. And so what we see is that people who the machine classified as very low risk have a lowish risk of 1-year mortality. I mean, still 10%, but that's very low for this population. Lowish risk of 1-year mortality, low risk a bit higher, medium higher, high higher, very high higher. Within each of those risk buckets, we then separated out the patients for whom the provider said, oh, this risk, your risk seems too high, your risk seems too low. And to give you an example of how this would work, if you look at the high risk group here, so the machine thinks this person is high risk. If the provider says your prediction is too low, their risk is even higher. And if the provider says, your risk is too high, their risk is lower. So to see evidence that providers are meaningfully modifying the prediction made by the machine, you want to see kind of this like downward slanting pattern across these categories. And there's some hint of that, but it is not dramatic. And it's interesting. I think there's a lot of pushback from providers when it comes to predictive models, that it's like, well, a machine will never see everything I've seen, and I have this clinical gestalt. But in fact, most of the data suggests that we're not that great at that, particularly when we're trying to prognosticate things that are in the distant future. And a year away when someone's hospitalized is pretty hard to do. Ask a provider if a patient's going to be on dialysis in the next 24 hours, and they'll get it right 95% of the time. Ask them if they're going to be on dialysis in the next week, and things fall off pretty quickly. Did showing this information to providers make a difference? No. Which maybe shouldn't be surprising, because we didn't tell them to do anything, right? And that was the first lesson we got from Elia 1, which was you can't just give information, you have to couple information to some kind of action. And so just providing that information, like Cassandra, whether it was accurate or not, didn't change 1-year mortality, didn't change 30-day readmission or inpatient mortality or a composite outcome of all of these things. In the future, if we were to design this again today, we would have specific actions coupled to your risk category. So we would say, oh, this patient is high risk. Maybe they should have a palliative care consult, or maybe they should have a VAD consult, right? Like there are things that we can sort of facilitate. And I think that's really key when we think about clinical decision support. So some take-home points on REVEAL HF. So predictions, however accurate, are only beneficial insofar as they change outcomes. And I try to convey this to hospital administrators, not just here, but at Gaylord and at other hospitals that I've talked to. There's a lot of very slick AI companies that will come and tell you how great their model is at predicting anything, whether it's ICU transfer or no-show rates at clinics or hypoglycemia or readmission within 30 days. And they may be, trained on whatever data, they may be very accurate. But accuracy is the table stakes for these types of models. You have to have an accurate model. Now you can, once you have an accurate model, now you can start doing things with it and trying to see if an accurate model of 30-day readmission the use of that model can actually prevent readmission. And those are very different things. But people figure that out, I think. As I said before, purely informational alerts may not meaningfully affect provider behavior. And we're really interested in how we can integrate human and machine gestalt and start to pick up on what humans are learning and what machines are learning and how we can kind of work together to make our predictions even more accurate. So I've whirled through 4 completed trials, some of our learnings. And in conclusion, the take-home points here is that all this stuff we do in digital health and clinical decision support and artificial intelligence is about applicability. These are very cool tools and they're getting better by the day, but if we can't show that they benefit patient care or patient outcomes, they're not very useful. The most amazing prediction is useless if it doesn't change outcomes, and common sense can lead you astray. For those of you who are entering into the world of clinical research or thinking about stuff like this, I've noticed a lot of trainees are very nervous when we say the word randomization. It sounds scary and you've got to deal with clinicaltrials.gov and things like that. But it's not bad. Once you start randomizing people, you'll like it even more. And if you need any help, please reach out and we'll help you get started. Big team at Citra that are responsible for all this kind of stuff. And so I won't list out everyone, but I will thank everyone. It's a great team and some of the people who are outside of Citra that help us quite a bit as well. And I think, I finished with a few more minutes for questions. Thank you very much for your attention.
Thank you, Perry. That was great. So the floor is open to questions. Dr. Yagi.
Thank you. That was really interesting and such a clever way to do these pragmatic clinical trials. I had two questions. One, I was sort of curious, more from a methodologic standpoint and sort of ethical standpoint, the decision of when you consent providers for participants. I think in the AKI study, it was a very large, I assume there wasn't consent occurring, but I think you mentioned in the heart failure study, which was a cluster, you did consent providers. And I was wondering if you could speak to that a little bit.
Yeah. So there are 4 criteria for obtaining a waiver of informed consent. Number 1 is that the trial cannot, or the study cannot meaningfully be conducted by getting consent. And in theory, you're not supposed to say getting consent would be too hard. In the case of the AKI studies, what we can say is, if we consented someone with AKI, we would have to say to them, you have AKI, oh, but you got randomized to the control group. So, don't tell your provider that you have AKI because we want to see what happens, right? And that just obviously would ruin the study. So that's number 1. Number 2, it can't interfere with the rights or welfare of a patient, that's normally we don't like to do that no matter what. Number 3, it has to be a minimal risk study. So this is where there's a lot of discussion about risk. One of the issues in ALIA 1, our first alert trial, was what do we put in that AKI order set? So for example, should we put a fluid bolus in the order set, not checked automatically, but just there, because that's the kind of thing that people might want in an AKI order set. And the IRB said no. That would be a passive endorsement of the idea of fluids for AKI, and some people would just click whatever you tell them to click. And that elevates the risk above minimal. And so our order sets were kind of naturally like very, it's urinalysis, bladder scan, kind of non-invasive things that we could leave as minimal risk. When it comes to the cluster randomized trials, I think, we could have made an argument not to consent the providers, but because we could and it was feasible and there wasn't a scientific reason given that it was cluster randomized, the only argument we had for not consenting the providers was that we didn't want to let them know we were watching, right? So there's this Hawthorne effect where if the consent form says we are studying guideline-directed medical therapy and heart failure and we're tracking everything you do, they might start doing better, and that's artificial. So we did work with the IRB to get our consent language actually somewhat vague for that study. And so we didn't say, the primary outcome is an increase in the number of GDMT and here are the GDMT. It was kind of you're going to be seeing some alerts or you may not. They have to do with the care of patients with heart failure. So we did think about that. Yeah.
And one last question. Thank you. We were hearing today in a faculty meeting, I think Dr. Steiner, there are over 500 signature clinical pathways in EPIC right now that I think physicians, providers need to look up to implement, but it seems like really low-hanging fruit to investigate whether those pathways actually improve outcomes. We believe they do based on best evidence, and I'm wondering if there is any push from your group or at the institutional level to sort of do these types of pragmatic clinical trials to evaluate these pathways.
Yeah, I would love it, and I brought that up to the pathways committees several times, but no, there hasn't been much movement to evaluate these things in a randomized fashion. They're very keen to get kind of as many up and running as possible, and some of them are very useful actually. But I do have concerns. I'll say, for example, on the AKI clinical pathway, because I was on that committee, there's, first of all, the pathways don't exactly adapt to the patient. They're kind of standard based on criteria, and then you have to figure out where you're going down the lines. But for instance, in the AKI pathway, I was asked, well, should we recommend discontinuing ACE inhibitors or not? And I gave the same response I told you guys. Well, maybe, but the blood flow will increase. I don't know. There's no good data, And in the end, they said, we'll just recommend to discontinue ACE inhibitors. We need something. And, standardization of care is good probably, but I do worry a little bit about over-standardization when we don't know what the best practice is in a given situation. That said, some of our data suggests, at least for some of these pathways, they're not being used so much that I think it's polluting the well too much when it comes to evaluation of other things.
Thank you so much. This is excellent, and I think whether people like it or not, these tools are here to stay, and they're only gonna become more important, I think, over time. And so to that effect, and kind of dovetailing off of Dr. Yagi's question, how do we balance these clinical decision support tools with the already high burden of data and clicking within the chart? I mean, I think that's something that all of us struggle with.
Yeah.
And when you have like 5 pop-ups for a patient for different diseases and disease processes and mortality and so on, it becomes very easy to just like click out of them and ignore them so that you can do what you need to do in the patient's chart. So how do we get the most bang for our buck for all of these different tools without making it yet more of a burden for providers?
So yeah, you're describing alert fatigue. Well described, actually started in the ICU, and not with electronic alerts, but with the beeping of ventilators and IV poles, and people just literally stopped hearing those sounds. I mean, your brain just turns them off. This is a huge problem with clinical decision support, and there's a couple of things you can do. Number one, you should eliminate alerts that are ineffective, and effective should be ideally defined by improved patient outcomes. It's hard to improve patient outcomes. It's okay if we say effective is, getting people on their sub-Q heparin that otherwise wouldn't be, even if we don't get that next step of, and they have less DVTs and death. But I'd love to see clinical outcomes. I think you do that by, if we're going to have a quote unquote learning health system, you create the infrastructure to do these. This is A/B testing, right? You don't just decide something's a good idea and turn it on. You randomize it. One of the things we worked with with the IRB, and actually Alan Chow and Neetu Kashyap have endorsed this, is that people in the hospital will soon start getting in their admission packet a standard bit of language that says, hey, we might test these things on you, alerts and information to your provider, which they can opt out of, and there's a mechanism to opt out, but sort of an opt-in consent for this type of study. And I think that can be really useful. And maybe it should be part of the culture that if you are concerned that, patients are falling because they don't have the bed rails in the right place, and you want to create an alert to do that, it's actually quite easy to say, okay, it will automatically happen in half the patients, and we'll come back 4 months later and see which is better. The final thing we can do to eliminate alert fatigue is to take things out of the hands of the providers. So there's things that are highly successful in medicine that make your life easier. For example, titration of heparin with heparin protocols. When I was in training as an intern, we had to stay up and look at the PTT and then make some arbitrary decision about how to change the heparin drip, and then order another PTT and wait for that to come back. I spent all night titrating heparin drips, right? And now nursing driven. When I was an intern, we sent our patients to the lab to get an INR when they were being anticoagulated. And then we would look at the lab and we'd make some arbitrary decision about what to do with the Coumadin dosing. And now that's all driven by algorithms, often led by nurses. And taking things out of the hands of providers can be really effective as well to reduce that fatigue.
So the hour is late, but Dr. Mathey has a question that I'm sure we all want to know the answer to. So it'll be our last question. What questions or trials should we be doing in pulmonary and critical care?
Oh, that's interesting. You're more expert than I am. I mean, I think these types of interventions there's a lot that you guys can do for your patients. I mean, for example, any question of titration of your parameters, whether it's vent or drips, blood pressure targets, et cetera, are amenable to this type of intervention, right? You can, and I'm just not expert enough to know where the literature is and what's the missing step, but I think there's quite a bit, because the interventions that work best for this, or the stuff that works best for this, are things where there's something, structured in the electronic health record that you can trigger off of. And you guys have a lot of structured data. And two, where the outcomes are fairly proximal. I don't think inpatient alerts are going to affect 5-year mortality from, stage 3 colon cancer. So where we're going to see the effect is in very ill people that have high inpatient mortality and stuff like that. So I think the ICU is a good place for this kind of work.
Thank you very much. That was excellent. Oh, yeah. Yeah, where the actual RAS compared to a recorded one. Thank you so much.
All right.